We're going to talk about thyroid nodule. Thyroid gland is situated just below your voice box. It's like a butterfly gland which is there across there. And the gland, if it starts becoming bigger, we call it nodule. So anything which grows out is nodules. Nodule is very common disease across the world. It can be as high as almost 30 to 40% population can have little small nodule to bigger nodule. And thanks to the iodized salt that what we have in the country, that amount of goiter what we used to see in 60s and 70s have come down drastically. But we still feel a lot of thyroid nodule. Thyroid nodule needs to be investigated. That's why I'm going to talk about it. And it can become bigger because thyroid nodule can be as simple as benign conditions, which is nothing at all, and it can be cancerous. Because thyroid cancer is common in young people and old people, those who have history of thyroid cancers, and exposure to radioactive substances also can cause risk of cancer. So in young people, we need to investigate. Now, these symptoms can lie silent without causing much symptoms, and it can be just routinely found on an ultrasound or other Doppler studies, or somebody else noticing the thyroid glands. And those glands which have pops out quickly, we are not that worried about. Those who are there for some times and are bigger and hard, that's what we are worried about. So mainly they may be symptomatic, asymptomatic, and if it's symptomatic, it's because the thyroid gland is situated around your windpipe and food pipe. So if it becomes bigger, you can have some difficulty in breathing, and if it becomes bigger and can press your food pipe, you can have difficulty in swallowing. There's one nerve which comes very near to it, and that can lead to hoarseness of voice. So you can have difficulty in breathing or difficulty in eating and hoarseness of voice, and these are the three main features that you can have. And usually, and they are very slow growing thyroid gland. So the causes of thyroid nodule can be benign, which is non-cancerous, or can be cancerous. And I must tell you that this has to be investigated based on the certain guidelines, and sometimes it can be cystic, very fluid filled, which you are not worried about it. And it can be simple colloid nodules, can be follicular adenoma, which are little solid, compared to the malignant, which is cancerous form of thyroid nodule. So thyroid ultrasound is a quite basic ultrasound, which is just like a jelly scan over the neck, which is done. And in that, we need to have the status of the thyroid nodule, how much thickening it is. Is it normal thyroid gland? Is it much, the shadow is much thicker or darker compared to the normal thyroid? And what's the level of calcification or calcium deposits around or the center of it? Or what are the blood supply across the margin? So we need to have very standard thyroid ultrasound done, which can tell us more about when we feel the thyroid gland by examination. Sometimes the back portion of the thyroid glands are not visible. So thyroid ultrasound remains a very standard tool for looking for nodule. The next stage of this is thyroid scan is done, mainly where the TSH is little lower, no normal side. We do not recommend thyroid scan to every people. The thyroid scan is just like a little mini CT scan done, which you do, give you a dye, and takes around 10-15 minutes time to get your thyroid scan done. And most people with thyroid nodule, which is approximately 1 centimeter or larger, should have their FNAC. The tissue should be taken out to look for any cancer. And there are different criteria for it, but majority of the more than 1 centimeter nodule should be FNAC'd. And if it's less than 1 centimeter, if you have high risk population or suspicions and ultrasounds are towards the cancerous side, they should have an FNAC done. The FNAC done usually can be blind without doing an ultrasound, or can be done with an ultrasound probe. So we can do both way in our hospital, where we can have an ultrasound guided one, or it can be just done if it's very palpable nodule, very superficially. Now, the thyroid nodule found, we need to make sure we also correlate with thyroid function tests. And once you find an FNAC, sometimes the FNAC can be very non-diagnostic, and sometimes it can be diagnostic, and sometimes the scan can be suggestive that it is borderline and the thyroid FNAC needs to be repeated, sometimes in 3 months time, sometimes 6 months time, or years time. So thyroid gland, all the time you may not get a diagnostic results. You can have a benign or non-cancerous one, if it's, and can be found in cancerous one. So it's a different type of cytological prescriptions can have it, a benign, a follicular lesion, and a follicular neoplasm. Once we have thyroid cancers diagnosed, I think we're going to discuss the plan, but most of them require the removal of the thyroid gland, or partial or the complete. And after that, we do certain radioiodine investigation to find for any residual thyroid glands, either in the thyroid A bed or anywhere in the body. And based on that, we plan the treatment, which